Hello, and welcome to One World, One Health, where we talk to people working to solve some of the biggest problems facing our world. I'm Maggie Fox. This podcast is brought to you by the One Health Trust, with bite-sized insights into ways to help address challenges such as infectious diseases, climate change, and pollution. A One Health approach recognizes that everything on this planet, the animals, plants, and people, and the climate and environment are all linked. A perfect example of how we're all connected is the problem of antimicrobial resistance, or AMR. This happens when infectious bacteria, viruses, or fungi develop the ability to withstand drugs and other treatments. So, when a person or animal gets infected with one of these superbugs, it's harder to cure them. Sometimes infections become completely impossible to treat. It's such a big problem that the United Nations and other major organizations have focused on it throughout 2024. To help guide these international discussions, the Lancet Medical Journal commissioned a series of papers led in part by the One Health Trust. Joseph Lewnard, an associate professor of epidemiology at the School of Public Health at the University of California Berkeley, helped write one of these papers looking at ways to prevent infections in the first place. Simple hand washing can do a lot, so can clean water and vaccines. Lewnard is joining us in this episode to talk about what works. Joe, thanks for joining us.
Thanks for having me.
Joe, we've been talking a lot about how dangerous these drug-resistant infections are and how many people they kill every year, but there are ways, and some of them are pretty simple ways, to prevent infections from ever happening in the first place. Can we talk about what some of those are?
Well, there's several dimensions of what we should do to address antimicrobial resistance and the burden it causes. But the first, and perhaps most impactful, will be preventing resistant infections from occurring. One setting out of many that we should be thinking about this is, of course, within hospitals and other healthcare environments, because many of the most severe, most dangerous, and most difficult to treat infections are acquired in healthcare environments.
Can we talk a little bit about what you mean by healthcare environment?
Healthcare environment, the first one that we think of, and I think that perhaps one of the more important ones that we think about, is hospitals, because this is where the most severely ill patients are seen. It is also where patients may receive the most invasive care, for instance, in the context of surgery or in the context of patients who are stuck in a hospital for long extended periods of time. These are some of the circumstances under which the concerns about acquiring dangerous and resistant infections may be greatest.
And of course, one would tend to think that a hospital or a clinic should be the safest place you could be, but it's not, is it?
Unfortunately, I think that it's not always the case that this is the safest place we can be. Of course, there are risks of acquiring infections in the community as well, but we do see that many of the most severe infections, those most likely to cause death, and some of those that are hardest to treat, are acquired in hospital settings. And this can also be because there is extensive use of antibiotics in healthcare settings and selection for some of the most resistant phenotypes of pathogens out there.
So one of the things you looked at and talked about in this paper is hand washing, and that seems so basic, and yet it's harder to do than it seems. You looked at healthcare facilities where you would think hand washing would be universal, 100%, right? But you found that healthcare workers, including nurses and doctors, were only able to follow hand hygiene 43% of the time. That's less than half in low-income areas, and they just hit 65% in high-income countries. How can that be?
Well, I think that the first thing that we need to think about, especially when we consider low and middle income country settings, is that in order to be compliant with recommended hand hygiene protocols, the physical infrastructure needs to be there to make it convenient and routine for people to engage with hand hygiene the way that they need to do that. And there are many settings where even in hospitals or in healthcare facilities, hand hygiene is not actually an easy thing to achieve, or is not a convenient thing to achieve for providers who may lack access to the appropriate physical infrastructure, or who are swamped with the challenges of delivering patient care under very difficult conditions. Of course, you mentioned also that there is unmet potential even in the higher income settings, which is true. And this is true of, many behavioral interventions in general, that attaining the 100% kind of compliance that we would like to see can be difficult.
You talked about achieving the infrastructure that people need. Can we take that to like plain language level? What do you mean by that? Do you mean sinks? Do you mean hand dispensers? What do you mean by that?
It can be as simple as access to a sink with soap. It can be also, in some instances, where having delivery of clean water and removal of waste where that's not achievable. It can also mean water-free wash stations.
What other types of hygiene can help?
Well, as we look beyond just hand washing, this is a cornerstone of preventing infections in healthcare facilities, but we also need to think about use of sterile instruments and the environmental cleaning and sterilization that needs to occur in order for patient care to be delivered safely.
So in other words, clean needles, clean catheters, clean rooms. Okay, what else can be done? How about vaccination?
Well, we looked not just at infections that can be prevented in healthcare facilities, but also infections that occur in the community, which is where a very large proportion of AMR selection likely happens. And so there's several dimensions of how we need to think about preventing infections in the community. Anything that reduces antibiotic use is, of course, important because use of antibiotics is an important part of how we select for resistance in bacterial pathogens. In addition, delivery of vaccines that prevent resistant infections, such as typhoid conjugate vaccines, or implementation of improvements in people's physical infrastructure, such as their access to clean water, their access to sanitation in their homes and in their communities, can help prevent infections that either are resistant or that lead to antibiotic use, which we want to ultimately prevent whenever possible.
So some of these antibiotic-resistant infections can be prevented with vaccines. Which ones can?
This is important focus, I think, especially for typhoid conjugate vaccines. So infections with typhoid around the world have seen an increase in the proportion that are resistant to some of our most important medications for treating typhoid. And so the delivery of typhoid conjugate vaccines over the last 4 or 5 years has been an important part of how we aim to mitigate the burden of resistant typhoid, which of course can be fatal. In addition, there are other vaccines which target pathogens for which resistance might be of concern as well. Some of these include Streptococcus pneumoniae, which is an important bacterial pathogen for which we have pneumococcal conjugate vaccines in use in most countries now. Others include things like Group B Streptococcus, for which vaccines are in the pipeline, or Shigella, for which, again, vaccines are in the pipeline.
How about if you vaccinate people against other infections, ones that aren't necessarily drug-resistant infections?
This is actually one of the most important and I think one of the most interesting stories about the role that vaccines and other interventions, for that matter, can play in reducing the burden of drug resistance. Most of the impact that we estimate can be achieved through vaccination actually occurs through reduction in antibiotic treatment of things that may be viral infections. So things like influenza, RSV, rotavirus are all important contributors to the occurrence of acute respiratory and diarrheal infections that account for most antibiotic treatment of children, but where etiology is rarely, if ever, known at the time that patients seek care in clinical settings. So very often what happens is that people unnecessarily receive antibiotics to treat these infections, both due to patient preferences for receiving antibiotics when they are ill and the difficulty that providers face in navigating potential to treat an infection for which they don't necessarily know whether bacteria or viruses are at play in causing it.
So, in other words, if people get a virus, the antibiotics aren't going to help, but doctors often give them antibiotics anyway, both because people ask for them and also just to be safe.
That's exactly right. Providers face a difficult dilemma in this situation where maybe there is a risk that a bacterial pathogen is not necessarily the cause of illness that somebody's experiencing, but they have only one opportunity to treat that patient, especially in low resource settings. And so use of antibiotics might be an important first line approach, even when there is a only partial likelihood that bacteria are responsible for the illness that an individual is experiencing.
And of course, reducing the use of antibiotics in the first place is a major goal. Could you tell us a little bit about other ways that you can reduce the use of antibiotics?
There's a vast number of infections that occur each year that cause antibiotic treatment, some of which, as we've mentioned, are bacterial, some are viral, and some are caused by other types of organisms or even chronic disease processes. Unfortunately, we don't necessarily have perfect interventions against each of these specific etiologies that we might consider here, but we know that improving the quality of physical environments that people live in can play an important role in reducing their risk of illnesses that result in antibiotic treatment. So we know that, for instance, people experience lower risk of diarrheal infections and acute respiratory infections when they have access to clean water, appropriate sanitation infrastructure for removal of waste, access to hand washing facilities with soap, and where they can take basic precautions that we often take for granted in high-income countries, which help to reduce the incidence of a vast variety of infections and ultimately reduce the incidence of antibiotic use.
I mean, you mentioned some stuff that many people might take for granted, as you said, like something like just access to clean toilet facilities where they're not sharing one toilet with a lot of other people.
This is a great example of one of the key interventions that we need to make more widely available. There are many settings where toilets are not necessarily available, or they do not dispose of waste in a facility where people will not come into contact with it again, or where, like you mentioned, it may be inconvenient to use latrines or sanitation facilities simply because they're not located in a place that is near to where people live, or perhaps in a situation where accessing these facilities may not be safe, and there is additional concern associated with going out into community sanitation facilities or making use of shared sanitation facilities.
When you talk about access to vaccines, can we kind of explain that to people? Does that mean that they're brought to countries, they're brought to your homes? What do you mean by that?
How we deliver vaccines can look different in different places. One consideration is that countries need to commit to having these vaccines in their national immunization programs for children. So the first barrier to acquiring all the vaccines that we'd like people to receive is whether the countries have made a commitment to delivering these vaccines and making them available. The second is, even in countries where vaccines have become part of their immunization program, there might not be universal uptake of the vaccines, perhaps due to a lack of access to medical care or inability to deliver vaccines to hard-to-serve populations, for instance, those that are residing in rural locations where cold chain requirements for delivery of vaccines poses challenges, or where there is reluctance or hesitancy to receive vaccines.
Can you give us some examples of countries that are doing it right and countries that aren't necessarily hitting some of these vaccine targets, and they might be countries that surprise you?
Rwanda is an interesting example that you might think of as a country that ostensibly is a low-income setting. People, unfortunately, do not have access to the same standards of living and life expectancy as we might take for granted throughout much of the rest of the world. However, they have made enormous strides in delivery of primary healthcare services, and vaccine coverage reflects this. They do very well with delivering vaccines to children. Their expanded program in immunization would be broadly seen as a success. Brazil is another example where, even though many of the people who might lack access to some of the services we take for granted, for instance, those living in favelas or in even relatively remote communities, still have access to vaccinations and do very well, and are also accepting of vaccines in large part. There's also countries that we think have the capacity to do better but do not. And unfortunately, the United States is an example of this, where primary health care leaves a lot to be desired. Acceptance of vaccines remains inadequate, and some of the benefit that we could achieve in prevention of infectious disease is not realized as a result.
This is so interesting. What are some other things that you see that countries or governments can do?
One of the parts here that I think is essential, aside from making sure that vaccines and other health interventions that we think of as health interventions are broadly available and broadly used in populations, is making sure that water and sanitation infrastructure is delivered at the highest level that can be attained. To date, some of the investment in water and sanitation infrastructure for low and middle income country settings has either been inadequate or non-existent, or has focused on interventions that only come part of the way towards the goal that we need to attain. And by this, I might, think, for instance, of installing, but not necessarily maintaining, some low cost and ultimately inconvenient hand washing or sanitation or water facilities. The standard of water, sanitation, and hygiene that's needed to actually prevent infections is in fact fact higher than some of these kinds of temporary or slapdash interventions we've seen in the past. And trials undertaken recently in places like Bangladesh, Kenya, Mozambique, and other settings have shown that low-cost, suboptimal interventions that do not necessarily make high-quality water and sanitation facilities easily and conveniently accessible to people don't actually achieve what we want to achieve of preventing infections. So I think that this is an area where we need to really think of water and sanitation and hygiene interventions look like in places like the United States and Europe and high-income countries, and try to maintain that standard and make sure that people who are currently not having access to that standard of water, sanitation, and hygiene can attain it.
So what you're saying is cheap and quick doesn't always work.
Unfortunately, that's the case.
Wow. Joe, this gives us so much to think about. Thanks very much for taking the time to join us on the podcast.
Thank you for having me. It's a pleasure to talk.
Listeners, if you enjoyed this podcast, please share it. You can learn more about this podcast and other important topics at onehealthtrust.org. And let us know what else you'd like to hear about at OWOH@onehealthtrust.org. Thanks for joining us.
Thank you for listening to One World, One Health, brought to you by the One Health Trust. I'm Ramanan Lakshminarayan, founder and president of the One Health Trust. You can subscribe to One World, One Health on Spotify, Apple Podcasts, or wherever you listen to podcasts. Follow us on social media at One Health Trust, one word, for updates on One World, One Health and the latest in research on One Health issues like drug resistance, disease spillovers, and the social determinants of health. Finally, please do consider donating to the One Health Trust to support this podcast and other initiatives and research that help us promote health and well-being worldwide. Until next time.